landing stations here. Just as I said, right, let's go, John. He disappeared. I don't know if it's something I said. I'm trying to racking my brain as to what I was talking to him about, and then he suddenly just ran for it. Don't think I offended him. Can't be sure though. Anyway, welcome to episode 28. I'm sure he will be back shortly. I'm keeping an eye on my phone just in case he buzzes me and goes, what's happening? Welcome to, yes, episode 28 of Sports Therapy Association podcast, as it is officially called now. Hey, Caroline, how you doing? It's still Let's Talk About, but I tend to call it now more Sports Therapy Association podcast because that's what it is. It's very exciting as well. I uploaded another 3 sessions today, including Keith Burnett's up there, and also, who else did I put up there today? Also, our very own Tom Colwill is up there. And also Nicola Elwood, I put that one up, communication mindset coach, very topical because a lot of you will be using her services again, I'm sure. So that was a really, really inspiring one that I encourage you all to listen to about how to get the best out of yourself. And that's how to get the best out of your business during, once again, these difficult times for soft tissue therapists. So have a look at the podcast. Obviously, please leave a review, be nice. Especially on Apple Podcasts. iPhone users, the power is in your hand. The success of the podcast rests in iPhone users. It's still about 70% of you. So do please go to your iTunes app, not your iTunes, your iPhone app, and just leave 5 stars and just say it was great. And that'd be wonderful. If you're not on Apple and you're Android, then you need to actually go into iTunes on your laptop, which I doubt any of you are going to do. So iPhone users, the onus is on you. Let's say thank you. Oh, good. John is now here. Fantastic. He's back. Wasn't anything I said, was it, John? That's fine. It's okay. He's just told me that it was fine. So we'll bring John up shortly. Can't go first. We've definitely got to say thank you to Gemma, fantastic Gemma Oliver. We've had some great feedback. Thanking Gemma for her time. Gemma is the creator of the Physio and Therapist Support Group. And despite my tricky questions in the beginning, it is obviously clear that Gemma is a key player in the breakdown of the traditional kind of walls between therapists, which is what the Sports Therapy Association is all about, isn't it? It's about you. It's about what you do. It's about your name rather than if you're an osteopath, a chiropractor, or physio, or sports therapist, or whatever it is. Now it's about you and the service you provide. So Gemma's group on Facebook, Physio and Therapist Support Group, they were doing a poll about your favorite quality street chocolate the other day, which was amazingly entertaining. So it provides support in many ways which you might not expect. I do encourage you to go along there and hang out a bit. And it's a wonderful mixture of different disciplines. You can see a lot of people are in the same boat. And you can check out Gemma's not on the podcast yet, but you can check her out on YouTube. Okay, which again, click that subscribe button. I think we're over 200 now, which is fantastic. We're catching John Gibbons up slowly but surely. So fantastic. Yes. So tonight's guest, yes, John Gibbons. I'm sure a lot of you have heard the name before. I would be surprised if at least probably, I don't know, 30% of you haven't done one of the courses. I was surprised if 80 or 90% of you haven't got one of your books or seen his books on your bookshelf or in clinic. It's a great treat to have him along. He's just released his latest book, The Vital Nerves. In true, I mean, it's such a nice book. I fancy just talking for an hour about the beautiful artwork and the way it's laid out. It just draws you in just to read it. You know, some books, especially subject topics like this. I mean, I teach A&P, and I'm very, very quick to put down a book if it bores the hell out of me, because imagine what students are thinking. But the layout of the book is truly beautiful. It's just come out. I could see on the Sports Therapy Association group, a lot of you ordered it already. So I'm really looking forward. Use this thread if you like, once you have got it, to have a little chat about it. But we've got the actual man himself here to talk about the book, The Vital Nerves, which I'm very excited about. It's a total hole in my knowledge. Looking after runners all this time, even now I'm thinking there's going to be a lot of bombshells here. Well, I should have been doing this. I should be doing this. But I'm going to sit back and let you guys ask the question. So without further ado, let's bring up author, multi-book author, and international lecturer and presenter and training course guru and king, Mr. John Gibbons. How's that for an intro?
Like it.
Can you live with that, King?
Yeah.
How you doing, mate? Thanks so much for giving up your time. I know we were talking off air. You've been particularly busy, haven't you?
Thank you. Thank you for inviting me.
Tell us again what you've been doing.
Yeah. Well, just today, yesterday my books arrived, so I had 350 turn up on a pallet. So then I had to obviously unload 25 boxes of the nerve books, and I'd already had 250 envelopes already pre-done. So then I had to sign them all. So I was still signing books till 11:30 last night. And then I started early o'clock this morning till 10 o'clock this morning. And then I went to the post office and took about 240 books, I think it was. So the postman, the post office were smiling.
Imagine being the person in the queue behind you.
Yeah. Well, it's actually a drop and go. So it's...
it's not too bad.
Yeah, but even so, the man's face, when I brought in another 100, he's like, "Oh my God, do I have to do them today?" I said, "Please," because all my therapist students who I've taught over the years have been not hassling me, but they've been asking me every day, "When's the book coming out, John?" I thought it was last week, I thought it was last month, but now it's finally here, which is great because it's there.
Look at that.
This is the hardback version,
Yeah,
so I'm very pleased.
It's a beautiful book, mate. Really nice. Yeah, I'm going to say this is no stranger to you, and I mean, and I suppose, what sort of time do you normally have in between books?
I don't have any time. So I'm writing 3 books at the same time.
Wow.
I'm doing a spinal manipulation and mobilizing one, which I'm going to call the Vital Spinal Column, linking mobilizing to manipulation. Hello, Denise. Yeah, I can see Denise is there. Then I'm supposed to be doing a cervical spine one, and then I'm doing a vital knee one as well. So, but it normally takes me about 2 years. The shoulder one took me 2.5 years to write, because it was 105,000 words. So, and the pelvis one took about 2 years as well. So, so roughly about 2 years. I started in 2010, so I've done 7 books in that period. So our plan was to do 10, but I'll never stop. Thank you, Faye.
You can see the love for you is huge in the room. The word legends being used, kind of like thrown around. You've definitely got it was really nice seeing the support for you online. I mean, that must be really nice to see that your work's actually being celebrated and people are really keen to get hold of it.
Yeah,
you've been around a while, haven't you? Let's face it. You look like a young man, but you can't be that young.
No, I'm actually 52.
There you go.
Yeah, so I've been around, but then I didn't really start. I was a late starter, if I was honest, because I joined the army at 16, and I left the army when I was 27. So I did 12 years. I did, but I did 5 years as a physical trainer in the army. So I guess when I say late starter, maybe in the osteopathy therapy world in some respects. But then the army paid for me to do sports massage, sports therapy with Premier, but it was in my last year, so I did that in 96. Yeah, 95, 96. And then in 99, then I started teaching for Premier. And then I was based in Wiltshire, then Cardiff, Bristol. And then they asked me to go to Oxford, where I was like the main therapist teaching. And then that's where I studied osteopathy and started in 1999 and finished in 2003. So, yeah. So quite a while. Yeah, and I've been running that clinic for 18 years at Oxford University Sport, where most of probably the people who have bought my books and attended my courses have probably been too. Yeah, I think in my prime, I was probably teaching about 200 a month, maybe.
Wow.
It varies. I've taught more than that. I've taught 130 a day. I did a course in Perth last March, I think, for the Scottish Massage Association. And it was in a big, massive sports hall. And I think I had something like 60 couches and about 130 students for 4 days. About 3 days. And then I did a nerve course, which is the last one. And I think I had about 60 students for that one. So quite a lot.
So a lot of people have been through the Gibbons stable then. Fantastic.
They have. Yeah. And I actually did 32 flights last year teaching. So I spent a lot of time abroad, in countries. So and when I teach in places like China, they always have about 90 people on the course. So it takes a while because they don't speak English. I don't speak Chinese.
We're going to have you back to see how you went from Premier. I mean, I remember Premier back in late 90s.
Yeah.
And how you went from that to traveling around China and Thailand. And we'll have to have a whole episode on just how you did what you did and how you achieved with your millions of YouTube followers and stuff. But for now, it's going to be, I mean, it would be interesting to hear about that. And it's inspiring as well, because it literally is somebody who went from the army. It's the same success stories which we've had with a lot of speakers. And it just shows that I imagine the answer is going to be passion, self-belief, people to support me, that sort of stuff. But it's all about this tonight. Gary has said, actually, in case you haven't seen in the comments, I mean, if you listen to the podcast, by the way, this is if you're listening to the recording, please do not use your phones because your call will not be registered. There is a thing going on at the moment for the live people who have joined us. Gary has said, please share this chat with your therapist friends. We will draw 2 lucky winners to receive a signed copy of John's new book, The Vital Nerves. Okay, so that's people watching the live. If you're at home, please don't call in. I've always wanted to say that. Right. So yeah, this book, I mean, it's obviously part of a series of books you've had. If we just bring up, so I had a little look at Amazon to remind me, your most famous book, which most people know you for, was the MET book, yeah? And I think
the MET one, yeah. Well, I guess it's my first one, and most universities and sports therapy courses will have it as a read-in list. So a lot of the sports massage, sports therapists will probably have that book. I guess it's a little dated now, so we're looking at doing an edition 2 at some point. That's another one I've got to be doing at some when I get my head around that one. It's a pretty
staple one. I think even Mike James has got it on his shelf. You know, he loves to show. You're friends with Mike. You know Mike quite well, don't you?
Yeah, I know Mike well.
Fantastic.
Yeah.
I can slack it off find his back. That's great. When he's got his look at all my books behind me that I've probably never read, but he's always. I'm sure there's a few of yours there as well. He's got. But yeah, I looked at.
I gave him the shoulder one. He did like a little commentary on it. The shoulder one 2 years ago.
Your accents, I don't want to generalize here, and I'm probably miles apart, but I mean, your accents seem quite similar. Is that because of a regional thing, or is it just my bad ear?
Regional, yeah, because I'm from Aberdare originally, which is near Merthyr.
Okay, so not too far away from him.
No, because he's based near Cowbridge now.
Oh, okay.
So, yeah.
Gotcha.
So he's Welsh, yes.
So we can see here, I mean, the vital glutes, the vital shoulder complex, and this one is yours, the functional anatomy pelvis, the sacroiliac joint.
Yeah, that's mine as well.
That's all yours up there, recommended author, you. What made the nerves come along now? I mean, I was, when I saw it posted, I was like very excited because if anything, my bias is too much with the nervous system and everything. So I was like, wow, this is great. John Gibbons with the Nerves book. Beautiful. Because I love the layout of your books. Like I say, I'm very visual.
Yeah.
And I've had a look to this. It hasn't let me down, but was it just the next one in a series, or was it a reflection of kind of some of the things we're seeing these days?
Yeah. Well, I always say to my students, like the nerves, when I try to promote the course, because it's part of my diploma, I always say, well, maybe leave the nerve course till the end, because it's probably the most complex one. And I honestly think that given a choice, a lot of therapists that I've taught wouldn't probably have done that course with me, but because it's part of my diploma, they end up doing it. And I always believe that out of all the courses I teach, it is the most important component of all aspects of therapy, I believe. And once the students have done the course, then a lot of them have said, wow, I've enjoyed that course so much. When are you going to be writing a book on it? And I go, oh God, I'll write it one day. One day I'll get my head around it. And slowly, it sort of like came together. Like when I was taught like nerves and neurological testing as an osteopath, they spend so much time on cranial nerves. And I've been an osteopath for 18 years now, and not once have I really used that bit that they spend so long teaching us. Like every patient who would come in, we would do the cranial nerve test in, but in reality, my clinic now is mainly Oxford University students and staff. So the majority are going to be the 22-year-old that runs a play sport. I've looked after the boat race team for 10 years. I haven't done it in the last few years, but they're all in that sort of age bracket where they're not really going to have a potential neurological issue with the cranial nerves. Mm-hmm. So I thought to myself, well, if I write a nerve book, I'm not going to spend too much time on that side. It's not the central nervous system, but it's the cranial nervous part of the peripheral. But because it's relatively complex, and as I say, level 3 or 4 sports massage therapists, they'll never really use it, and trying to assimilate the information and get taught it's really difficult. So I wanted to, put a course together that will help the sports therapist. So when a patient like a runner says, "Oh, my calf hurts," then Roger's simply thinking, "Oh, is it a calf pain?" It might well be, but it's the tibial nerve coming from the sciatic, which might be a problem with L5S1. So they might considered it's a neurological problem with the lumbar spine, rather than it coming from the calf. So that's the idea of it. But in my book, I've got loads and loads of case studies of patients that have seen me in the clinic. You know, there's like one in particular where he's got like numbness, like in this area of the hand. I'm not sure you can see this, but on the thumb space in here. But I was training with him in the gym, and I was ex-military, and he was ex sort of military. He was an American trained at Oxford University, and he was in Iraq and I was in Iraq, not quite the same time, but sadly he was shot and a bullet went through him, but it went through his arm and obliterated the radial nerve. So he ended up with like a wrist drop, or drop wrist, you know, it doesn't matter what you call it. And he basically couldn't extend his wrist because the nerve was completely obliterated in here. So, you know, just to talk to him and write about that story, and then what they did with him, they literally shortened the retinacle in here, so they lifted his wrist up, and then they redirected one of his flexor tendons to be an extensor tendon. And you know, just talking to him was just like in awe. So I thought I need to write about that. And then one of my case studies, you will see the picture where I show it as a bullet hole in his upper arm. But because it wasn't life-threatening at the time, the bullet went through him, and obviously they had to deal with that at the time. And then by the time they dealt with the issue with the arm, they'd almost left it too late to try to initiate the repair of that. Yeah. And even myself, you know, I talk about myself kayaking off a waterfall many years ago, and I went with some Marines, and I was probably about 25. And when I kayaked off, I didn't realize there's a big rock, and I dislocated my shoulder. And then when the shoulder was relocated in hospital, the nurse in the morning was sticking something sharp in my shoulder around this sort of area in here. It's called the regimental patch or regimental area. And basically she was sticking something sharp and I couldn't feel it. And what I'd done, I didn't know at the time because I was a 25-year-old, you know, physical trainer. I didn't really know about nerves and stuff like that. But what I had done, I damaged the axillary nerve because of a dislocation to the shoulder. So I'd lost the sensation to that particular area. It's almost like a circle, so I couldn't feel it. But you know, people might say to me, "Oh, it's a C5 dermatome." I go, "Well, yes, it might be a dermatome, but the dermatome area will be wider, and also C5 obviously relates to the C5 nerve root. So it obviously innervates the muscles that supply the abductors of the shoulder and the elbow flexors." Whereas the axillary nerve, if you know about it, which comes from the brachial plexus, which is C5 and C6 origin, only supplies the deltoid and the teres minor. So it doesn't do anything to the bicep muscle because that will be a different nerve, which is the muscular cutaneous nerve. So it's a different area. So, you know, it's almost trying to work it out. And because I was a vehicle electrician many years ago, I think about like a dimmer switch in some ways. I use that analogy where if you put the dimmer switch on, the light is bright. And obviously if you turn it, where you add more resistance, the light goes dim. So for instance, if the tube, which is the wire, and the wire might be the nerve, is being compressed by, let's say, a disc, then obviously it's going to affect either the sensory input coming in, yeah, or the motor output going to wherever it's going to. So and then the dim, you know, the light is then dim, so the muscles are going to be weaker. So when you test them, you might say, well, grade 5 is normal on a myotome, whereas if it's a power of, say, grade 3, then you might find it might be a neurological issue. It might not be. Yeah, it might just be that the muscle is weak because, you know, you've strained it. But that's why you have to try to differentiate. Is it a muscle weakness because you've strained the supraspinatus, so it hurts when you lift the shoulder? Or is it because you've got a C5 nerve root problem? Or is it because you've got an axillary nerve problem? So
how accessible, I mean, this sounds amazing, an audience, I'm thinking I'm missing stuff out here, but how accessible is it to, for example, our audience range from sports, let's imagine L4, like a level 4 sports massage therapist. There's obviously loads of case histories and tests in your books, but do you think it's something that therapists should be adding to their repertoire and is not being done enough? Or
yeah, well, the problem is you've got is like osteopath messaged me yesterday about promoting the online courses, and he's saying about people like copying the techniques and practicing the techniques. And I said, well, most of the therapists will already be qualified. Yeah. So so it's not like they're starting from scratch. It's not like you know, like a window cleaner is going to like click onto my, you know, vital nerve course and do that. He's going to be probably a sports massage therapist, so he'll already have training to do that. Whereas like neurological testing, the sensory side is relatively straightforward because you're only going to be using like a cotton wool or like a neuro tip. But when it comes to the use of the reflex hammer, the patella hammer, you can try and use it because you're not going to cause a problem, but you would probably need to do some form of training. I'm not saying like by me. It's only because I watch many tutors teach neurological testing with the use of a patella hammer. But when I watch it, I don't tend to say that much because I don't feel that it's my place sometimes. You know, I'm almost sounding negative if I'm, you know, saying, oh, don't do it like that, do it like this. But when I watch, I think, well, if you just change the positioning of the patella hammer and you hold it towards the end rather than holding it towards, you know, the heavy bit, and you let the weight of the hammer just contact the thumb rather than just tapping or hitting firmly, you might find the reflex is then elicited, and then it will be a 2+, what they would call it. Whereas when I watch a lot of people, I think it's not going to work. You're not going to get a reflex by doing it like that because, one, you're in the wrong area. You know, you might find the bicep tendon, you're not physically on it, you're on something else. So anatomically, you need to know what it is you are contacting. And secondly, you might find that if you say, looking at Achilles, you'd have to place it into a little bit of stretch. And if you just physically tap the Achilles tendon, you are not going to get a reflex. And then you miss out then thinking, or they don't have an S1 reflex. So the problem must be an S1 nerve root problem coming from the L5-S1 disc. And then that person might see me and I go, and I tap the reflex and I go, it's okay. Yeah, but you've been panicking now. Yeah, because you've been told that you've got no reflex. And it's mainly because the technique was done incorrectly. So, but the bonus is that in my book, I do have QR codes. So you can physically use your phone and just scan it. And then you can literally go to it. So you can watch the video time and time again. Buy a patella hammer. They only cost £10, £5, yeah, £5 to £10, depending which one you buy. And I suggest you buy the Queen's Reflex one, which is the longer plastic one, rather than the Taylor one. Yeah, that was designed by Madison Taylor in 1888. Yeah, so it's you know, it's been out a while. Yeah, the triangular shaped one. And I remember, this is a funny story. There was one of my students many years ago now. I was teaching a neurological testing, and I always give my students something, whether it's a book or the patella hammer, as part of the course. So basically, if you end up doing a course with me, I would give you the book, and that's what a lot of my students like, is they like to receive something. And people say, well, why don't you charge them? I go, well, why should I? You know, they pay enough for the course. At least I can do is give them a book. Yeah, and they go, you know, and I sign it, and you know, the little touches like that is maybe why, you know, sometimes my courses are busier than maybe others. But anyway, this young lady, you know, I watched her, and she literally used the rubber end of the patella hammer, the Taylor one. She started to rub out something, and she looked at me and she said, John, your rubber doesn't work. I'm like, it's not a rubber. It's a reflex patella hammer. She goes, oh right, oh sorry, I didn't. I thought it was a rubber. But you know, if we were all the same, life would be a bit boring, wouldn't it? So you know, did smile. Was that Mike James says?
He is. I was saving that.
For you. Is he there? Is he?
Yeah.
Tony Whitey.
He's appeared. He's probably been sitting there for 10 minutes thinking, what am I going to say to him? How am I going to throw him?
He can say what he likes, you know. In fact, yeah, Mike, you need. I need to send you my book to do a little discussion on it, please, if that's okay. I'm sure he will. Yeah,
Mike. Yeah, yours is in the post, mate. All right. Yeah. Yours is in the post. Yeah, should be with you soon, mate.
You know, anyway. In fact, I'm going to be in Wales soon anyway. So
that takes it, let's say, ages to get there if he's in Wales somewhere. Brian has joined us. I'm interested, people. So obviously, right, okay, it's been John's knowledge is incredible. I learned so much of John. It's been just all the way down. So this is a chance for you to actually put questions to John. I'm particularly interested in questions about the reflex hammer. Never used it. Never used it. Okay. Obviously, I've been lacking somewhere. I know that I think with a lot of therapists, I mean, I worked, most of my 8 years of practice was in a multidisciplinary clinic. So as soon as there was something which kind of fitted outside the norm, it was quite easy for me to say, normally there was this great physio, Paul, look after this, but there's something weird going on here, the sensitization issue or something, some kind of numbness, or it hasn't reacted to this pin. They can't differentiate between the areas. I go like that. But I get the impression that as therapists, with a little bit of help from you, there would be less referring out. We could do these tests ourselves.
You could do a test yourselves, but probably the ultimate goal. Let me give you an example. Let's say there was a lady that comes in and she literally walked in and she literally had her hand behind her neck because her arm was so painful. And what had happened is a few days earlier, she was on a fairground ride, like a waltzer, and her neck was just jolted. And so she comes in and she had this shooting pain all the way down her arm towards her middle finger. And to me, you know, because I've probably seen it often, I sort of knew what it was. And she said, like the night before, she would sit with her husband and have some food. And then she would then eat for like 30 seconds and then place her arm behind her shoulder again, because it was the only pain relieving position for her. And she had some very obvious radiculopathy, like shooting pain, mainly towards her arm. She also had it under the armpit around her axilla, but it was going down mainly towards the hand, the middle finger sort of area. And, you know, so from a dermatome perspective, you could almost look at a map and think, well, that looks like it's following a very definitive nerve root pattern. And you could say it's probably the C7 nerve root. Yeah. So, so that's one thing. And then the second thing I would then test her myotomes. And a myotome is like an area of nerve innervation, okay, like by a specific nerve root. So if you like cannot abduct your arms, then you might consider it's a C5 problem. If you cannot flex your elbow, it might be C5 and C6. If you cannot extend your wrists, it's probably a C6. So when I tested her, it was very weak on elbow extension. Hello, Yvette? I'm not sure if I've lost you here. I'm in stream. I'm not sure if people can hear me. I've lost Matt for some reason, but I'm going to carry on talking anyway. But she was very weak on elbow extension, as in on a grid from 0 to 5, 5 being normal strength. Then she had a strength of only, say, 1 or 2. So that meant that the C7 myotome was very weak. So then I tested the reflexes, and I tested the C5 reflex of the elbow, and that was normal, which we would call a 2 with pluses, so plus plus. I then tested a C6 reflex, and that was on the brachyradialis region, and that was also a 2 plus. But when I tested the C7 reflex, can you hear me, Matt? I can't hear you. Are we in? Hello? I'm not sure if maybe someone put a message saying you can hear me, because I can't see Matt anymore. Brian Huxley, can you hear me? Hello? I think I'm just on my own. I'm not sure. Danny, can you? Host has joined the broadcast. Gary. All right. Okay. All right. Okay. Thanks. Okay. So Gary just said you can still hear me. So so when I tested the C7 reflex, which is I couldn't elicit So that would be, you can call it like a 0 is actually a 1, 1 plus. So it's a diminished reflex. So it basically meant that the C7 nerve root was affected. So when you look at anatomy-wise, so she comes in with arm pain and weakness on certain movements, but then I'm telling her that more than likely she was more got a disc prolapse between the level of C6 and C7, which is contacting the exiting nerve root of C7. Now, in terms of treatment, it would be a little unrealistic to treat in one respect, because you think, well, what am I going to treat? You can treat, but you would need some guidance, because obviously the cervical spine, and you got this disc prolapse that's more likely present. So from a sports massage perspective or sports therapy, I suggest that you would write a letter to the doctor saying your clinical findings, and then I would say that the dermatome is affected to C7. The myotome was weak on C7. So, and then the reflex, C5 was normal, C6 was normal, and C7 was diminished. So then you might hypothesize, you can't use the word diagnose, but you could say, I suspect my patient to have a disc prolapse that is contacting the exiting nerve root of C7. And I recommend a MRI scan, to confirm or deny my hypothesis. Okay, so, but, when you think about what you would have written to the doctor will naturally look at that letter and think to himself, wow, who is this person? They'll be looking and they think, well, you're a level 4 sports massage, it doesn't matter what you are. But if you think about the professionalism that you did when you sent them the email or the letter, and then the doctor will hopefully remember your name, and then anybody that comes in with maybe some musculoskeletal type of injuries, I'm not saying neurological injuries, because you might find you end up naturally being, triaged to the neurologist, or the surgeon, depending. Because that lady in question, I referred her for an MRI scan, because osteopaths can refer relatively quickly. So we had a scan within a few days. She saw the neuro consultant within a week, because she had bupa, and I think she was operated on within 10 days. And he said to me, John, it was one of the worst disc prolapses I'd ever seen. And he said, because he naturally knew that I manipulate necks, and he said, whatever you would have done to this lady wouldn't have made any difference. I've just lost myself on that screen.
Can you hear me now? I didn't want to interrupt you.
Yeah, I can hear you. Yeah, but
that's okay.
Am I cut off?
No, I can still see you. There's some weird stuff going on.
Here.
Oh, really? I can hear you.
Yeah.
And I can see you.
Oh, there we go. Yeah.
Okay.
Something pop up. Yeah.
Something weird's going on, people. I'm sorry about that. I'm sorry, John. I didn't want to interrupt you. Everyone's going, we can't hear you, Matt. And I was like, well, I'm not going to speak now. He's on a roll. He's talking about stuff. Well, that I missed.
There was, but that's what I mean. So that use of a patella hammer would obviously, you would naturally test the asymptomatic side first, the non-painful side, to see what's normal, and then you would then test the side where she or he would be presented with symptoms. And then if you do notice, when you think about a reflex, we've got a picture of a reflex, haven't we, Matt, somewhere?
We have. Let me find it for you. Dun, 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 the classic knee. Let's bring it up.
Yeah, because someone asked me a question about how can you differentiate between a muscle tear. When you're looking at this picture, which is great, if I'm honest, okay? Like, I think all my pictures are,
they are beautiful
to do. My medical artist, she is so good. And in fact, she's got the same name as my sister, Amanda Williams, which is quite nice. So basically, when you tap the reflex, like in this case, we tap in the, well, medically is the ligamentum patelli, but obviously the patella tendon. So when you tap in, obviously it changes the sensation of the spindles, the muscle spindles, which obviously detect any change in length. So what they do, because the quadricep is innervated by the femoral nerve, which is mainly L2, L3, L4, there's a signal in particular that comes from, well, we say L3, 4, but it varies in some books. Dermatome You know, if you're looking at 10 different dermatome maps, they'll all be different. Like L5 in some covers the great toe, and in others it doesn't. It's and like C7 in books go all the way up the arm, and some just start at the wrist. But when you tap the reflex or tap the tendon, and obviously you have a sensory afferent nerve that's stimulated, which then goes into the spinal cord, and then there's what we call an interneuron, which is located within the central nervous system, which then synapses via the motor nerve, which is the efferent, and then goes to the same muscle, and then that muscle will then contract. So what it's simply doing is it's telling you if information is allowed to be passed through the sensory afferent, to integrate within the spinal cord, and then interneuron to synapse, and then for the information to come back out. So if there is like an open circuit, if you physically cut the wire, then obviously you get no response, from the quadricep muscle. Or if you've got compression of the disc, which is affecting the nerve root, then again it's going to be reduced. So the patella hammer will tell you a lot of information. So and I do have another one in my book on the C5, which is via the muscular cutaneous nerve, which I can see at some point. But also the reflex is very good because it also tells you if there's potentially like what we call an upper motor neuron lesion present. So another case study, there was a martial artist who came to see me, and simply speaking, he said, "John, my left leg doesn't feel like it belongs to me. My right leg, my right leg feels really strong, but I feel that I can't tell my left leg to lift and kick." He happened to see a therapist, who was a chiropractor, and he had 24 sessions, but it made no difference. But when I tested his reflexes, his upper reflexes were normal. So, so C5 and C6 and C7 reflex were normal. But when I tested his lower reflex, there's one of L3, which is the adductor, there's one of L4, which is the knee, and there's one of S1, which is the Achilles. When I tapped all of them, they seem to be very brisk. And I'm thinking, wow, that's a bit strange. So then what I did then was I did something very simple on the foot known as the Babinski Reflex, which is using the reflex. And then you're almost like you go from the medial side of the foot to the lateral side. And the idea is that the toes would naturally curl down. But if you've got an upper motor neuron, like multiple sclerosis or some motor neuron disease, or something affecting the spinal cord or the central nervous system, then you might find that you have what we call an upgoing plantar. So on his foot or feet, both of his reflexes, his great toe, if you like, and his toes went up and out. And I was thinking, that's not good. So his upper reflexes were normal, but his lower reflexes were increased. And I was thinking, there must be something wrong between the input coming in from L3 and then between L3 and C7, because from C7 to the brain, the reflexes were normal. But where the information was coming in from L3 going up, if you like, then something was affected in it there. He also had some symptoms around T9, 10, and 11. So I'm saying to him, I referred him to the doctor, giving him my findings, and I'm saying I think he should have an MRI for his lower thoracic spine because I think he's got some form of tumor around the spinal cord. And that's what it was. So when they scanned him, and then he obviously had to have almost immediate surgery because he had this tumor that was contacting the spinal cord, almost like a central disc prolapse, maybe like in the cervical spine. You might find that it affects the reflexes. So the reflexes basically become brisk. So they would be graded as a 3+. So by using that simple tool that costs £5, it could tell you so much information. And the idea is, at the end of the day, you have to look after your patient. So you're almost making sure that it's a sign of health. So these reflexes can tell you a lot. You might have other symptoms to go with that. I did see a lady once where she had a hip problem, and I said when I assessed her, it was more likely like a labral tear, but it didn't seem to fit the picture the way she was discussing. And I'm saying to her, was there any history of anything in the family neurological? because just the movements and some of the symptoms she was presenting with just didn't quite fit. So I referred her to the doctor, asked him to maybe just do some investigations, and then she comes back and she basically had the diagnosis of MS. But she came to see me with a problem with the hip joint. So that was like an interesting one in some respects. And strangely, she asked me, well, what do you think about my hip, John? And I go, well, in reality, I think the hip is almost inconsequential, to the diagnosis you've got. So, so if I was you, I would focus on, every day and just take it as it comes, because you never know what's around the corner. Yeah. So,
so these are incredible examples. I mean, presumably they don't happen that often. You're not going to get two people in the same week with kind of a systemic issue like that. But what about on like a daily level? You work with a lot of sports people as well in the boat team. Can you give us some case scenarios where doing the stuff you do, for example, using the hammer or doing the tests, helps like with everyday sports people?
Well, with the rowers at some point will always have an issue with their lower back. And the thing is, when you have sort of like neurological conditions, then it obviously going to affect the musculature of the lower limb. And I'm not saying you have to use a patella hammer, because another quick way, and I think one of my pictures is where the Denise, she was on there earlier, I'm not sure if Denise is still there, where I'm using her to do some testing, where basically you walk on your heels and you walk on your toes. And you can almost say to your patients to do that, because I'm not saying you screen in the neurological system, but it gives you an idea. So if you've got a boatman where they talk about some weakness in the leg, it doesn't really matter whether it's on the anterior or the posterior. They might find they're doing some, oh, she is. Yeah. So you might see the model, Denise, obviously my woman. So she's I'm not sure what page that's on. Well, I'm testing the L4 and L5. But in a simplistic way, if you ask your patient to walk on their heels, you're almost testing the L4-5 myotome, because L4 is mainly tibialis anterior, and L5 is mainly EHL, which is the extensor hallucis longus. So, so by dorsiflexing the ankle and extending the foot, you are almost ruling out the L4-5. I'm not saying you're ruling it out completely, but it just gives you an idea if you've got some obvious weakness to the nerve. And if you walk on your toes or you do a simple calf raise, then that's trying to elicit a response from mainly S1. So by walking on your heels and walking on your toes on athletes, you might find, I've seen many an athlete where they might not have done it in a sport, like the rower might have picked up like a kettlebell, on the floor, and a heavy one, and then think, oh, I've just done something to my back. And then 2 days later, he's like, John, I've got this like pain in my leg. And then I would then quickly test the reflexes. But then if I didn't have a reflex hammer with me, if I'm at by the river, let's say, then I might just do some strength tests. Sometimes it's very chiropractic in some ways, because there's a friend of mine, he's a Canadian chiropractor based in Vancouver, and I watched him look at the rowers. And from a chiropractic perspective, he would basically test the myotomes, which is testing the neurological system. So he would test like the hip flexors, which is basically testing like L1, 2, 3. Knee extension would be testing L2, 3, 4. So he would run through a muscle tests of the lower limb. And depending what he found, he would then know what level of the spine to manipulate. Because obviously from a chiropractic perspective, they would consider that everything relates to the nervous system. And if you've got a vertebra that's subluxed, obviously it's going to interrupt the neural pathway. So then they would test it. They would use the hand or the elbow or the wrist, and they would know exactly what part of the cervical spine they would target without using any hammers. So they would almost use that. They would use hammer as well. But when I watched my friend Mike, he didn't use any hammer. He screened them by doing the muscle tests, which was, and then what you would then do would retest. So you would test the power. Even in one of my YouTube videos, one of my friends on the course, well, one of my students, he was on about his weakness of his arm, and but there was no pain or weakness. So I ruled out like a rotator cuff tendinopathy, but and I resisted action, and it would say a grid 3-4 out of a 5. And I also tested elbow flexion, and it was a grid 3-4 out of a 5. And I'm saying to him, it might well be that it's a C5 nerve root. I didn't do a reflex test on him, but then I adjusted his cervical spine, and then I retested, and then, you know, happily we retested, and the strength was back to normal. So that's on one of my YouTube videos that you could actually see that. Obviously, I don't promote cervical manipulation on my course because I almost refuse to teach it. Yeah, and I'll only teach osteopaths and chiropractors who are at their end of training or who are already trained to fine tune. You know, it's probably not a good idea for maybe level 4 sports massage therapists to start manipulating necks, because I always say to people that you might end up going down a path you can't get back from.
Yeah, I don't think insurance will cover it too much.
Well, they do. They do.
Do they? For a heavy
you can't get insurance. Yeah, so I could teach it and they could get covered. But you know, I've almost promised myself that I won't be teaching. Obviously, I teach manipulation to other areas, but you know, it's only because I've manipulated maybe over 100,000. And every single one would have been slightly different. But trying to teach that to a newly qualified student who obviously wants to learn how to, you know, I hate this word, crack the neck. You know, or can I have a go at that? You know, you make it look so easy, John. It might be easy to me because I've done it 100,000 times, but it's definitely not easy. Yeah, and it's a scary process.
We got a question here from Lisa. Lisa says, so would you check, let's put it up on the screen. So would you check the vertebrae in general if you have a suspected nerve injury, or was this just a special case because the great toe went up and out? The material artist, sorry if this isn't a good question. Every question is a good question, Lisa.
Yeah, well, on him, when you say check the vertebrae, that's an interesting one, because when you think about how deep structures are, you know, sometimes I'm almost a little sarcastic sometimes, because I almost say to my students, what you think you're on, you're not. You know, they might say to me, John, I'm on the L5 facet joint. And I go, you definitely won't be. Yeah, because it's a lot deeper than where you are. So it's an awareness for the position. So when you know, you might find that if you come on to like this case study in particular, this T9, 10, 11, where he had his spinal tumor. Yes, the thoracic spine was tender, but you know, it doesn't really mean it's a problem as such, because it might relate to something else. And positional wise, then there would be no change. So T9, you know, wasn't rotated left or right. T10 wasn't rotated left or right. And that would be an awareness for it. And then motion testing at that level, if you are able to test it, you might find would test as normal. So it's a tricky one. You know, obviously the MR scan or CT scan would be the gold standard, yeah, in looking for any pathological changes within these vertebrae. You know, if you've got a disc problem at L5S1, if you physically put pressure directly onto the L5 spinous process, yes, it might be tender. But then it depends on how much pressure you use, because it might be tender because you're using too much pressure. You know, so it's a, you know, it's a real awkward one sometimes to look at that. If I'm honest, you know, like I had a guy, he was having mid-thoracic pain, and a 25-year-old, and I said, what exacerbates your symptoms? And he said, when I eat spicy food and drink beer, my mid-thoracic spine gets worse. So when I feel his mid-thoracic spine, it's stiff, it's painful on contact, pressure, but also overlying, he had like a skin changed. So when I brought my 2 fingers down overlying, it went red very quickly. So there was a very obvious erythema. The skin was very dry, very, what they call trophic changes, where skin, like dry and scaly. But it was in between around T5 to 9. And when you look at that, from a neurological perspective, that is the innervation. It's like the sympathetic nervous system is so important, like all the autonomic nervous system, you know, the parasympathetic. But that originates between T1 and L2 and is known as the thoracolumbar outflow. And S is for stress. So that area of your body controls, you know, the stress response. So between T5 and T9, where it is innervated is basically, like the organs, the majority of the organs will come from that. It'll go into what they call the celiac ganglia by what we call the greater splanchnic nerve, and it basically innervates that area. So I'm saying to him that more than likely you have got a problem with one of the organs, and it'll probably be the stomach because it's related to eating and food, whether it's before or after. Yeah, and I'm saying to him, you might find you've got an ulceration within the stomach. But he comes to me, so I referred him to the doctor, and the doctor did some tests, and he had a bug called the Helicobacter pylori bacteria within the stomach, which he had to have it eradicated. But he's basically, and then they found like an ulcer within the stomach, which was then causing the viscera to refer to the soma. So he was having what we call visceral somatic pain. He said, "Oh, John, could you just crack my back?" And I go, "Of course I can. Yeah, but I'm not going to change your symptoms." He goes, "Well, I'm sure you will." You know what I mean? So you almost feel obligated and pressurized, being like an osteopath, to crack his back. And I'm going, it won't work. It won't get rid of your symptoms, because you're probably tonight going to have spicy food. He goes, "Yes," and a few beers. And I'm saying, just if you can, go to the doctor, get it checked. And that's what he come back with. And I had an ulcer, and it was referring. But sympathetically, it's control from that area. And then for you to calm down is then the parasympathetic, which is mainly the vagus nerve. And I know there's books just on the vagus nerve. It's frightening, really, the information on just one nerve, one book. It's crazy. And obviously it comes from the cranial sacral outflow, which is cranial nerve 3, 7, 9, 10, yeah, and then S2 to S4 of the sacrum. So it's innervated, and it's the rest and the digest sort of area. So this guy, yes, he's got some tenderness to T5, 9, but his area overlying, because it's called medically, it's called a sympathetic tonia. So it's like an increased tone of the sympathetic nervous system. So that's why the hair follicle and the sebaceous glands are overactive. The localized muscles were very taut, almost very stiff, and it just made the joints very stiff. And I always say a tight muscle is a stiff joint, and a stiff joint is a tight muscle. If you've got A, you've got B, and if you've got B, you've got A. So you can't really do one. If you massage the area, it might feel slightly better, and if you manipulate the area, it might be slightly better. Yeah, but when you think about it, he was having referred pain from his stomach, so it's called a visceral somatic pain. And if you don't get that dealt with, I had a lady comes in with lower back pain and had been there for a while. She also mentioned to me about fibroids. Most men, might not know much about gynecological disorders, but it's benign tumors on the uterus. And basically, she even said to me, "John, they're so big, they're almost like the size of pineapples. Do you want to feel them?" I go, "Okay." So she literally placed my hand. I'm like, "Wow!" And it almost like these masses within her lower abdomen region. And then she ended up having a total hysterectomy. And then when they removed everything, a few weeks later, when she comes back to see me, she has no back pain. Mm-hmm. So more than likely, the organ was obviously referring to that sort of area of the spine. So. It's a tricky one, really, because any spinal pain could be coming from anywhere. We have to try to consider it as a musculoskeletal of origin, from the muscles and the tendons and the ligaments and the joints and all that stuff. But sometimes it doesn't always fit that. And that's why red flags are so important. And, to screen the neurological system. I'm not saying you can fix it, because more likely, if you start in using patella hammers and dermatome testing and myotomes, then more than likely you're going to get someone else involved. Whether that's, like you were saying, Matt, you referred to the osteopath or chiropractor, or whether you simply say, "I'm not sure what's going on here. I think it's best if you see the doctor." Sooner rather than later, especially like with things like cauda equina syndrome. Like if you've got a central disc prolapse, because the cauda equina, the spinal cord ends around L1. Yeah, and then it becomes what they call the horse's tail, as I'm sure you're familiar. But obviously, if you've got any contact to that area, then it's a very, medical emergency, really. If you have any changes, and sometimes the therapists don't ask questions about, any altered sensation to bowel and bladder, but you should ask almost, any lower back pain, any changes, to bowel and bladder, then you should be asking these sort of questions.
We've been fortunate enough to have Bill Taylor and Gonya Donnelly. Was it Gonya Donnelly or Emma Brockwell? Or all three of them, I think. They've all been. We've had a male and female pelvic health extravaganza double act on in the last couple of weeks. So the therapists in here are well in tune now with asking about not just do you have any problems, but being a bit more specific, like, you know, do you manage to get to the toilet or have you had anything? So yeah. Well, look, it's 8:57, so that shot by. Who would have thought? So as a word of advice, and obviously the first step, if therapists are interested in this, would be to grab this, add it to the collection. I mean, it really is a beautiful book, and just for, apart from the subject matter, the anatomy and the pictures are just beautifully done. So full, you know, hat off to your artist. And it's wonderfully laid out. The case studies in particular are fantastic, and it's always lovely to see it put into action, into clinical practice. So, but apart from buying the book, if people are, and you can just direct them to your courses if you want, but if people are interested in expanding their knowledge over reflex testing, and what would be the first kind of course, or apart from getting the book, they would go on? Presuming, you know, it's difficult now in COVID-19 times, but
you say that, but you know, I probably postponed 50 courses from March, which then I didn't really want to do it at the time because I thought, well, how can you learn online? But obviously I was almost forced into doing the online courses, and I'm so pleased I've done them, because like my shoulder course contains over 100 lessons. Like the Vital Nerves is actually my most popular. It's my least popular face-to-face, but actually on my online, I've got more people enrolled for that one. So I suggest you probably maybe look at that. The bonus is that the book is included as a PDF. So you almost have to go through each chapter, fine tune, and then you watch the videos. And like lesson 3 is about the cervical and brachial plexus, and is probably 10 videos just on that one lesson. So you almost have to go, but if you don't get it, you can almost like stop, go to sleep, wake up the next day and then revisit that lesson, but you do it in your own time. It's not like, the problem is coming to me on a face-to-face sometimes, I talk fast and I'm almost going from one stage to another because I've got so much to get through. Whereas with the online stuff, it's almost slow time. And I suggest you do an hour a day, maybe have a break for a day and then do an hour a day, and just slow time. It will take you 3 to 4 weeks of slow time doing it, but it's lifetime access, so you can literally go back, watch a video, go back, watch a video, and things like that. So yeah, someone said about spinal, but I suggest, and then obviously if you use the discount code, you can use Osteo15, or you can use I think I've got STA 15 as well, so you get 50% discount.
Yeah, definitely.
Yeah, as part of that. So the course is about 125, but it's about 70 lessons, and then you get an assessment. So I'm not sure how many chapters I got in here, 13 maybe or 12. So it's 12 assessments. So it's literally ongoing assessment for each one. And then once you've done it, you can then get you a certificate, and then you also get 21 points CPD. So you know, if you've got a few hours to kill, it's not drastic money. You can ask me questions as you go through on the posts, or you can send me an email. And then I think that's probably the best one. And then when I am running face-to-face next year, then maybe if you attended the face-to-face, which obviously I'd let you do it for cheaper, because that's the idea, is like my diploma. Once you've done my diploma, you can then do my future courses half price.
Right.
Which is a bonus, really. And even my online stuff, once you've done my course, you can then do all of them half price. So, which is great. Fantastic. And then I'm continually, like I did another video. Thank you. Yeah. She's done my courses a few times.
Rachel Buckland, for those who listen to the podcast, just saying, John's courses are incredible. The knowledge you come away with is invaluable.
That's very kind. She's done lots of my courses. Yeah, so I'll probably suggest maybe doing that one. Yeah.
Fantastic.
And I'd probably, maybe the book, because you can buy the book on my website. The softback version is £20, but then it's free delivery. So, you know, it does cost me about £4 or £5, plus the PayPal charge, plus me going to the post office, plus me signing it and writing it and posting it. So, you know, I don't make drastic money, but I don't want to make money from the book. I want you know, therapists to read it and to help their patients. And because when you're looking at nerve books, you know, I've got quite a few nerve books, but they're like an old bottle of wine. They're on my shelf, and every now and again I bring them out and I look at them. I go, "Oh God, I can't." Within a page or two, I put them back. I blow the dust off, and the font's too small. I can't read it. I have to put my glasses on, maybe, and it just goes back on the shelf. And I look at my shelf there, and I got maybe 300 books. How many of them I read? Not many, but I do hope hand on my heart that people actually like my books and actually read them. And the pictures help because the pictures are very colourful.
No, they're great. That's a lovely layout. Right. Yeah. Thank you so much for your time, John. It's a great book. And so the course has already started for this, or is there time? When does the next one start?
Well, there's no starting point. It's if you look at my website, John Gibbons Body Master, and look at online courses, if you click on the nerve course,
it's already start whenever.
Start whenever. It's already done.
Joy. Positive things coming out of COVID.
And you can also see what's included. So maybe just go and have a look to see, click on the course, see what is included as part of it. And then obviously if you don't like it, just let me know, say, no, John, I don't like the course. I would happily swap you to another one. Yeah, I can just grant you, I can stop one and transfer you over. But most people, 99% of the people attending it, and I've got almost 200, are loving it, and the feedback has been amazing. And also, there's so many extra videos on there that are not on YouTube. So, the bonus is that, and I did 23 videos last week, so I've got a few more videos to add in.
So there you go. There's the website, bodymasterclinic.co.uk, and plenty on there for you guys to be having a look through. Thanks, John. I mean, they're still commending you and saying thank you so much and everything in there. I think it's going to be another return visit, as we're finding so much with this lot. They can't get enough of the people getting in, which is great. Mark Newsy just said, wow, that was immense information given in 40 minutes. You will have to revisit on YouTube. Thanks, John and Matt. Yeah, thank you, Mark. John, a pleasure. Thank you so much for giving us your free time.
No worries, mate. Yeah, happy.
And like I say, in a month or so, then it'd be fantastic. Maybe we'll have some people who have done your course and they can talk about it live next time we come back on. So appreciate it, mate. Thank you so much.
I'm doing one on functional anatomy at the moment. So I spent a week just doing the ankle and foot complex. So I'll have an anatomy one up and running this month. I've got to go do the elbow, hand, and wrist. I've done most of it now, so that's going to take me another couple of weeks just to do that one. So but the pictures will be, the bonus is because I'm part of Lotus Publishing, I can use all the images and it's copyright free, which John Hutchins of Lotus has been fantastic for me. So thank you, John of Lotus.
Thank you, John, wherever you are. Yeah. Brilliant, mate. Thanks so much. What I'll do is I'm going to just put you down to the lobby, hang around, and I'll come and say goodbye in a second.
Okay.
But yeah, thank you very much, John Gibbons.
Thanks, everyone.
Wow, another one yet again. We always say it, don't we? Go back on YouTube, watch it again at half speed and take it all in. Loads of information there. Like I say, I mean, it's a lovely book. I've got a couple of others which I've accrued over the times in various clinics and things, but this one really is, in terms of, if you like quality anatomy and pictures and the way it's set out, it's really, really nice to read. I can say that. I still haven't gone through it with a toothpick yet, but in terms of just structure and the way it looks, then yeah, I would recommend it. Right, thanks, people. 9:05. Next week, not quite sure next week. I think it's going to be, obviously, with the changes, continuing changes with the guidelines. Then there's going to be an update with myself, Gary, and maybe a couple of other people from associations to help keep you updated. That's obviously something we take pride in on the Sports Therapy Association, of giving you as much support. And never has there been a time as now when you need to know what's going on, what's allowed, to try and help, hopefully, tempers not fray. So thanks as always for joining. Once again, 40, 50 of you or something in here, which is just totally credit to you guys as a group. I'm sure you've got better things you can do with your evenings, but no, we really thank you for that, for coming along live. It's lovely. And if you are listening to the podcast, then come along. I mean, it really is a great crack. People in there having conversations. There's stuff going on. There's banter. It really is a good shout out. So Tuesday nights at 8 o'clock at the Sports Therapy Association on Facebook. That's it. I'm going to love you and leave you. Thank you again to my guest, John Gibbons, and we will see you next Tuesday on Let's Talk About at the Sports Therapy Association. Take care. Bye-bye.